principles of ventilating a COVID patients. Now, I'm not going to set a sort of a prescribed recipe or prescribed setting like what we do with the standard ARDS, but rather to make everyone understand how lung injury occurs in COVID patients related to ventilation and how we probably should monitor and prevent these kind of complications. Now, right from the beginning of the pandemic, Getty Nolly has described basically two main phenotypes of the COVID-related ARDS. That's the L type and the H type, where L type basically stands for patient with a low elastance lung, that means high compliance, low VQ, which means they're more of a dead space ventilation, low lung weight, they're not really wet, and because they're not really wet, they're actually less recruitable as compared to the typical ARDS that we see in our previous management of ARDS patient, which is H type with a high elastance, high shunt, lung weight, and recruitability. Now, I don't see it as two distinct spectrum of disease, but rather it's more of a continuum of the disease process itself, where the L type will progress towards the H type, and most of them will end up in the ICU, where the H type constitute about 20 to 30% of the patients. Now, this could be due to the pathologic process itself, where there will be alveolar infiltrations and, of course, in COVID, microangiopathy. But what is more important and is more recognized is the ventilation-induced injury. Now, why I say ventilation-induced injury, I'll explain in a while. And this is the part that we're going to focus on in this presentation. Now, when we talk about ventilation-induced injury, we are focused on the standard barotrauma, volume trauma, atherosclerosis, and oxygen toxicity in ventilating ARDS. But what is more important is that understanding now has changed slightly, although the concept is still the same, where we understand it's more of a stress injury, where it's actually the distending force of the alveoli that causes excessive trauma to the alveoli, and strain injury, which is actually deformation injury, change the size of the alveoli. So if you actually look at the patients who are mechanically ventilated, this be known as ventilator-induced lung injury, and that most of us will know. But more importantly is that we have recently, not recently, it's been a few years that we're talking about patient self-inflicted lung injury. Now, this concept is still sort of controversial, but we in our ICU believe in it, and we do see it happening to our patients, especially if we delay intubation in this patient. When the patient is still left breathing spontaneously, supported with either a high flow nasal cannula or an IV, where they basically just breathe themselves to death, right? So let's just break it down into this stress injury. What does it mean by stress injury? Now, definition of stress injury is basically the pressure that develops within the lung structures onto which the distending force is applied. Now, in other words, this is actually the transpulmonary pressure. And it's actually a resultant of two pressures, which is actually the alveolar pressure and the pleural pressure. I think this most of us will know and understand, right? Now, when the transpulmonary pressure is actually transmitted into the, used to distend the alveoli, the pressure that is pushed in is transmitted equally in all sides of the alveolar wall, all right? So how does patient self-induced lung injury actually occur? So this happens when there is excessive effort from the patients, generating a very high negative pressure in the intrapleural space and causing a resultant high transpulmonary pressure. Now, of course, this is how the muscle relaxant actually help to prevent patients who are ventilated from getting really, that is by ablating the negative intrapleural pressure and causing a positive pressure as transmission from the pleural pressure into the intra. Now, but what is important here is that, most of us do exert ourselves, and we exert ourselves, we breathe hard and deep with large tidal volume. our lung don't get injured, right? Now, what happened in this group of patients is that their lungs are actually not homogeneous, right? There's patchy consolidation, there's a patchy deformity in the lung, right? In a normal lung, yes, no doubt the pressure is actually transmitted equally throughout the wall. But in a diseased lung, let's say if there's a diseased alveoli on this part of the lung, you can see that the alveolar wall that is actually tethered to the diseased part will be stretched. And the pressure that is building up in that area, we call it stress concentration, is 2 to 4 times the transparent pressure that's being provided to distend the alveoli. Right, with this pressure that's actually on board those stretched alveoli, it potentially can cause injury and rupture of the alveoli. So this is actually a animal model that was actually done by Cressoni that shows the initial relatively normal lung, right, with a bit of a consolidation here and there, and of course at the point of alveoli that is actually tethered to the pleural space and certain area of consolidation. After about 15 hours, maybe 24 hours, new densities start to form, caused by this stress concentration effect, right? So if the patient is actually left breathing spontaneously with a high transponder pressure, you can imagine the amount of pressure that's actually experienced by the alveolar wall over those areas and how the injury may actually occur. Right, and this is a historical cut of the animal model that we see here, where you see lots of inflammatory infiltration. Now, of course, besides the alveolar wall, there are actually interalveolar vessels stuck in between, right? In the area where there's actually a stress concentration stress tracer, this corner vessel or the interalveolar vessel will experience the same transmission of transparent pressure into alveoli, which lead to further injury to the interalveolar vessel. Now, with this injury, there is actually, it may cause thrombosis, it may cause a rupture of the vessel, a hemorrhagic vessel, as you can see here. And in the end, we actually cause an increase in the pulmonary vascular resistance. We couple with the ventilator strategy that we use on them. So some of the patients may actually go into acute cor pulmonale that we see in some of the patients where they get dilated RV, acute dilatation of the RV. Now let's go on to strain injury. What does it mean by strain injury? It's just basically a deformation, a change in the lung volume from a resting lung volume to the inspired lung volume. All right. Here we give a formula of a change in volume over the RC as depicted by this diagram. Now strain, there are two types of strain basically. There's a static strain, which is actually caused by a PEEP that we put on the patient, which actually expand the lung to a certain volume, and that's the end expiratory lung volume. And a dynamic strain is basically the one that's generated by the tidal breath, with each breath that the patient breathe or give to the patient. Now, how does injury occur? We actually have to break it down into looking into the lung fibrous skeleton, which consists of elastin and collagen. Now, this network basically can sort of expand to accommodate the change in the volume, where elastin, they're stretchable, they stretch to 1.5 times the original length, whereas collagen network, they're not stretchable, they're folded into a zigzag sort of a pattern, and when they stretch to 2 times its original length. Now, this is where the, when you stretch to 2 times the original length, this is where the total lung capacity comes in, right? So it's very unlikely in normal lung that we tend to overstretch the lung. So overstretching and rupture of the fibrous skeleton is probably not something that we will see very often. But because overlying this lung fibrous skeleton is the extracellular matrix where all the cells, lung cells, are actually attached to, the stretching and deformation causes activation of inflammation cascade from these lung cells. Now, when there's a disease in the lung occurring with consolidation, what will happen is that there will be progressive reduction in the functional lung volume. The initial tidal volume will set on a patient, although it's ventilating without much strain to the initial part of the lung, all right, will be too much for the residual lung to handle, because all the tidal volume that's being delivered will be delivered to the normal lung. And this normal lung will have normal compliance, all right? So if the compliance actually worsen, compliance is actually a reflection of residual functional lung volume rather than stiffness. So that's why compliance measurement is something that we do in the ICU regularly to look at how much lung is left behind for us to ventilate. If the compliance is poor, it's unlikely we're going to target a tidal volume of 8 mils per kilo. We're probably going to go down to 6 or even 4, depending on the lung situation. Right? So putting these two stress and strain injury into a bigger perspective, what we need to monitor and minimize lung injury, of course, there are a few aspects that we actually look at. We're talking about the etiological management, which is the antiviral. At this time, it seems to be quite futile. All right, convalescent plasma, which probably may have some role, but we have not seen a dramatic improvement in outcome. A pathophysiological management, immunomodulation, basically our steroids and TOSI, anticoagulation. And here is where we are, supportive management, where judicious fluid management is one of the mainstay of the management of a patient with ARDS. And respiratory support, which potentially can cause injury, but we try to minimize injury, all right? And this is the bigger framework of how we actually regulate and manage our ventilation in this group of patients. It is quite daunting, but the three main components of this diagram is basically managing stress and strain in non-ventilated and ventilated patients, and the respiratory drive, which actually drive the patient's self-inflicted lung injury in a spontaneously breathing patient, right? You can see some of the parameters here, which I've actually color code. Basically, P01 maximum oxygen pressure can be found in most of the ventilators, including stress index, whereas the orange coded are basically ventilator specific, right? And imaging EIT is also ventilator specific. But we'll go through one by one, okay? So when we talk about respiratory drive, what does it mean by respiratory drive? It's basically the neuroventilatory output from the respiratory center going to the respiratory muscles and driving the breath. Of course, the things that stimulate and increase respiratory drive is a lot. Generally, we're looking into hypoxia, hypercapnia, acidosis, hypothermia, hyperaneurysm. The black lung parenchyma disease itself, for example, edema stimulating the stress receptors. But in addition to that, in COVID, we found there's actually altered carotid body sensitivity to the change in the hypoxemia and also alteration in brainstem control. Now, this increase in the neuroventilatory output increase the drive, and the patients tend to breathe harder and deeper with a higher tidal volume, right? This is what we call a pendulum phenomenon, where there's a rapid and significant change in the pleural pressure and transpiratory pressure, causing that big swing in the pressure and big swing in the tidal volume that cause the stress and strain injury in the lung. And besides that, because of the aggressive contraction of the diaphragm itself will experience injury. Those of you who are into ultrasound, diaphragmatic ultrasound will actually shows a thickening of the diaphragm, not because it exercised too much, it developed muscle, because of the it is injured and it's edematous, right? When the respiratory drive is too high. Now, this is something that is difficult to actually monitor if they're actually not ventilated and they're allowed to breathe spontaneously. But because what we're looking for is that an increase in tidal volume and increase in inspiratory effort. Now, because their compliance of the lung is actually pretty good, what these patients will do in the L type is that instead of breathing harder with increased respiratory rate, they're breathing harder with an increased tidal volume. And sometimes it goes unnoticed by a lot of people. Unless you scrutinize carefully the way the patient breathes, you will notice that the breath is actually huge with the using more inspiratory muscle, more inspiratory effort. And occasionally when the condition get a bit more severe, they use accessory muscle to breathe, right? If the patients ended up with a central line, which at stage 3 or stage 4 is unlikely, you may actually see a swing in the CVP tracing, right? What we don't do, and which is tedious to do, is actually to put in an esophageal manometer to monitor, or a monitoring the electrical activity of the diaphragm. And anyway, this is not available to us at most of the time. And the patient, once intubated or end up intubated, we can use these two parameters to monitor that, and we'll actually go through that in a while. So when it comes to respiratory support of this group of patients, our experience here is that the referral will comes in at the stage 4. All right, these patients will be in the COVID ward. Once they ended up with an oxygen therapy, our team will be informed, and we will go and review and monitor the patients. It is good that in our hospital setup, we have actually incorporated mu score in this group of patients to actually pick up patients who are more ill, and they are actually referred to us quite early. So we will intervene. We will try to promote lung homogeneity with awake prone. At every step of escalation of oxygen therapy, we are looking into correction of hypoxemia, ablation of respiratory drive, and at the same time try to minimize any stress and strain. All right. Once they're actually up on a face mask, 5 liters, and that doesn't actually help much with the hypoxemia or the respiratory drive, the patient will be brought into ICU with a trial of high flow nasal cannula. All right. And we're going to talk about this in a while. And if this fails, of course, the patient will be intubated. One important point is that we limit the face mask oxygen to 5 liters per minute. I know there are centers that run the face mask at 10 liters or even venturi mask, but we don't do it here in our hospital. Practically, for this understanding is that there is so-called saturation PaO2 dissociation. It's not exactly a dissociation, but rather a shift in the oxygen dissociation curve to the left due to the increased dead space, hypocapnia, and because of the possible alteration in heme moiety in the hemoglobin, which lead to this shift to the left. So that means while the saturation may look good, but the PO2 can be quite bad or crap. So by allowing the ward to escalate the face mask to 10 liters, 15 liters, or even venturi mask, it may actually mask a worsening hypoxemia. So we tend to limit it to 5 liters and probably bring them early if the patient is not improving. And furthermore, we are also a bit concerned about what's the effect of using 15 liters of oxygen on a patient, whether there's any significant droplet dispersion. So it comes to high flow nasal cannula and non-invasive ventilation, bringing them into ICU. Now, what's the benefit here? I think the benefit of high flow nasal cannula has been known for quite some time. We've been using it for the past few years. Of course, it's titrable flow with FiO2. It helps to reduce work of breathing. It wash out the anatomical dead space, increase the NSP3 lung volume and humidification, right? Now, the statistics, you can actually look at it a few ways. I mean, most of the papers that come out, this is coming from Wuhan, it awarded intubation in 30 to 40% of patients, especially those with a PF ratio of more than 200, and if they responded with a reduced respiratory rate within 1 hour, and a ROX index. ROX index is basically an index where you use to monitor the therapy on high flow. It's actually a saturation over FiO2 divided by the respiratory rate. If it's actually more than 4.88, we're probably dealing with a successful therapy. If it's less than 4.88, probably you're going to fail, right? Although there's some paper that actually look into a higher number. But on the flip side, we're actually looking at 60 to 70% requiring intubation within 48 hours. And any delay intubation is associated with increased mortality. So the question is, how do we actually balance these numbers, these statistics? It's basically coming in, high flow nasal cannula, close monitoring, and low threshold to intubate this type of patients. Now, this is where the problem comes, because respiratory drive, high respiratory drive is one of the driver of lung injury. And when the patient is actually on high flow nasal cannula, they are still in the happy hypoxic group, where the oxygenation seems to be fine. They are saying hi, they're smiling, and yet they are hypoxemic in the PO2. On and off, they do get a bit tachynic respiratory rate, go up to 20 to 30. A lot of times we tend to hold them too long on the high flow nasal cannula, and that could be detrimental. Because what we want to know, what we want to see is not patient holding on to the high flow, but patient improving with the high flow. So the patient is holding on a high flow for the next 2-3 days. It's probably not very good news for the patient. Now, when it comes to non-invasive ventilation, let's include the CPAP. Our usage is usually restricted to the standard indications, because we do see a lot of our COVID patients coming with multiple comorbids, including those with COAD, those with a heart failure, coming with pulmonary edema and overload. Now, non-invasive ventilation definitely will benefit this group of patients. A trial of NIV on a hypoxemic failure has very little evidence, I would say. You may actually try on these are patients, but you have to select them appropriately. That means patients with a PF ratio of probably more than 150 or 200 in the absence of contraindication, with a very close monitoring to detect any treatment failure early and do not delay intubation. Because we know patient who goes on NIV, regardless of the type of patients, if they fail and delay intubation, they tend to have a poor outcome. But the good thing is that in NIV, we do have some degree of monitoring. Besides the clinical, we actually look at the tidal volume generated. On the flip side, because we're putting on an NIV, there is some support on the ventilation. The tidal volume generated can be quite huge, right? So this is the balance that we need to find. Whereas in the new Philips V680, it can actually estimate the driving pressure when the patient is still on the NIV. So how do we actually pick up patients who's going to fail the NIV? As I said, tidal volume is important measurement. If the expiratory tidal volume exceeds more than 9.5 mL per kilo of the predicted body weight in 1 hour, these patients are likely not going to be successful supported with the NIV. So probably we need to actually intubate them early. Another scoring system that I recommend you to use, although we don't use it very often, is actually the HACO score. I mean, this has been around for years. We know that it's actually sensitive. It has good positive predictive value of more than 80%. But it tends to be, it's not too tedious to score, but of course you need all these parameters to be in place before you can actually score them. And a score of more than 5 at 1 hour probably will tell you that patient will not do well on the NIV. You probably need to intubate them early. Now, of course, safety concern is there when it comes to putting patient on high flow nasal cannula and NIV. But there are a lot of publications, most of them are actually retrospective review, and some of them are using a patient simulator to look at the droplet dispersion. So this is one of the meta-analysis that I pick up from the Australians, where the NIV exposure has actually an increased risk to healthcare worker with relative risk of 2. Right, high flow nasal cannula seems to be quite safe. Right, the maximum dispersion distance was about 3 meters with a loosely fitted BiPAP running at 20 cm water, and 17 cm with a high flow nasal cannula at 60 liters. All right, but the conclusion here is very clear. Evidence is still poor. All right, but it seems to suggest that NIV is have more risk of transmission compared to high flow nasal cannula to the healthcare worker. But I would like to look at it this way when we actually want to decide whether we want to put a patient on a high flow nasal cannula in an open area or in an isolation room or even an NIV. All right. Now, droplet dispersion is actually dependent on the flow setting that you put. The higher the flow, the higher the risk. How well is the cannula fitting? You know, the high flow nasal cannula that we have actually has 3 sizes. Putting a too small size on the nostril will actually cause more droplet dispersion. And for the NIV, depends on the type of interface and the fit, right? I think our ED physician, they are more familiar with the helmet CPAP that has the most minimal droplet dispersion compared to a face mask and compared to a oral nasal mask, right? So it all depends on if the patient is actually on a high flow nasal cannula, whether the mouth is open, whether they cough. When they do cough, the dispersion of droplet is actually quite a distance. It can go up to about 90 cm, right? Even 2 meters. And additional of a surgical mask probably may actually prevent that. Now, there's actually additional condition is that the room that you put the patient on this, are they open ventilation, right? All the windows open, is the ventilation good enough to actually wash out this dispersion, all right? Do you have an isolation room? Do I have a negative pressure room, all right? How many patients are you putting into the room? The droplet load will be proportionate to the patient load that you have, all right? And the staff, the healthcare worker has to be protected at least with a option 2 PPE, which is a N95 if overall, if not a PAPR. So any one of you who wants to consider putting a high flow nasal cannula or NIV on these COVID patients probably need to look into not just the device that you use itself, but also on the environment that you're putting this patient in. So of course, if these patients fail the non-invasive method, invasive mechanical ventilation will be implemented. Of course, we can always start off with the standard lung protection strategy that we know, all right, with a tidal volume and a plateau pressure that is set, or setting based on the L or H type, where the H type is basically this setting, and the L type is basically when you know that the patient is less suitable, you put a PEEP of less than 10, with allowing a tidal volume going up to 8 mils per kilo. But I prefer to look at the whatever that we discuss, how lung injury occurs through the effect of stress and strain, and we can probably individualize to the patients regardless whether it's an L or H type or somewhere in between. All right, going back to the earlier diagram that I showed you. Okay, so driving pressure has been around for quite some time, and it has been made known again when Amato published an NEJM paper back in 2014, where from then on, driving pressure has become one of the mainstay of parameter that we monitor, fixing the driving pressure at 15, right? So what is actually exactly driving pressure? That is actually a number that we acquire, that we get when we do an inspiratory pause maneuver, which is actually the plateau minus the peak, right? If you look at the alveoli that was actually expanding and closing just now, it's actually driving the alveoli. Now, that means driving pressure is actually a surrogate of the transpulmonary pressure, all right? And from the Amato paper, we know that keeping them at 15 or below will probably have a reduced risk of mortality, provided that we are dealing with a normal chest wall compliance. So this driving pressure of 15 probably doesn't apply much on a patient with a rigid chest wall or a thick chest wall, like a morbidly obese patient. Now, when we talk about driving pressure, I want to relate the driving pressure to the compliance and the tidal volume. As I said, compliance is a measure of functional lung volume, right? So if the compliance actually reduce, as in here, and the driving pressure is actually fixed, the driving pressure itself will automatically drive the tidal volume down to a number that sort of fit the functional lung volume that's left behind, right? So that means if the patient's lung worsen, compliance drop, fixing the driving pressure at 15 will drop the tidal volume accordingly to what the lung needs. And this itself will reduce the cyclical strain injury, all right? And by fixing the driving pressure, inadvertently, you're also fixing to some degree the transpulmonary pressure. So that's why driving pressure is a measure that controls both stress and strain injury. And that's why it's being placed at the central of our ventilation strategy in nowadays. Now, of course, looking at backward, what tidal volume you want to set on the patient, if you know the compliance of the lung that you have to measure with an inspiratory pause, let's say the compliance is 20, you probably want a tidal volume just around 300, right? Looking backwards. Now, if a patient is breathing spontaneously, does driving pressure still matters? Right? Sometimes we do use a pressure control to ventilate the patients. all right, and we set a inspiratory pressure of 15, and we assume that driving pressure is 15. But when the patient is actually breathing spontaneously, there's a contribution of pressure from the muscle that drives the intrapleural pressure, right? Can this be worked out and measured? Yes, it can be worked out by, again, the inspiratory pause maneuver. So we actually do the inspiratory pause maneuver. What we have is that there will be a plateau, a double plateau. All right, it may peak at a certain point and then it plateau at a higher point. Now this upper level, part plateau actually reflects the extra muscular pressure that's generated to drive the lung. Now with this additional pressure of the difference between peak and the new plateau and the peak, the new plateau and the peak should be taken as the driving pressure of the lung. Although you may be, for example, setting the inspiratory pressure at 15, and the peak here is probably about 12. All right, so you're getting a, for example, 15 and 12 is, 27, and you get a plateau of a 30. Let's say disregard this part, okay, 30. So then your new driving pressure is actually 30 minus 12, which is 18, which is actually a bit elevated, right? So you need to actually control either the muscular activity or drive down your inspiratory pressure. So if the patient is ventilated, it's easier for us to pick up high respiratory drive because not all patients are actually paralyzed. Most of the time now we allow the patient to breathe spontaneously on the ventilator, right? But how often do we see patients sometimes who may be gasping and we feel that maybe it's okay to continue ventilating? But if you want to pick up that high respiratory drive, there are basically two maneuvers on the ventilator that you can actually use. One is actually the P0.1 and the other one is maximum end respiratory occlusion pressure. Now, where do you get this? Basically, the P0.1 is actually when you actually apply a transient occlusion of the flow in the ventilation during the spontaneous breathing. When the patient starts to trigger the ventilator, you apply a transient occlusion of just 100 milliseconds, which is actually 0.1 second, and you measure the pressure at that point. Whereas the maximum end respiratory occlusion pressure is when you occlude the flow for the whole of the single breath, right? That means you're going to cause a zero flow occlusion of flow for the whole single breath, and you see the negative pressure that's generated from that inspiratory effort, right? The cutoff numbers that we use here is P01 of 3.5. More than 3.5, if the ventilator gives you a positive number. If ventilator gives you a negative number, it's actually less than 3.5. That means 3.5, 4.5, 6, these are bad numbers. These are numbers associated with high respiratory drive, right? Maximum end respiratory occlusion pressure is minus 15 or lower. That means minus 15, minus 18, minus 20. These are bad numbers, right? And we don't want that. So how do we actually get these numbers? You guys are familiar with this machine, which is actually a PB840. P0.1 is actually located at the bottom over here under the LCRM, under the RM. It's not recruitment maneuver. RM is actually respiratory mechanics, where you click on the P01, you start applying. A lot of times we actually need to do 3 to 5 readings to get an average, right, to know how the patient is actually doing. So whereas the maximum end respiratory occlusion pressure can be obtained from a PB840 with an NIF maneuver. Right, you allow the patient to breathe spontaneously on the breath. You just hit on the NIF, hold it, this negative inspiratory force, right? Hold it, and it will give you a number. Certain ventilators like Marquet, it will estimate the P0.1 automatically right at the side of the screen here. Whereas Avia will activate the MIP, which is the maximum inspiratory pressure. It gives you both the P100 or P0.1 and the maximum occlusion pressure at one go, right? Something that we probably need to look into, high respiratory drive. Now, if you detect a high respiratory drive, what do you want to do? It's basically looking at the whole algorithm earlier. What drives the ventilation, right? Is there hypoxia, hypercapnia, acidosis, hyperthermia, hypermetabolism? Control the stimulus. If the stimulus can't be controlled, we will blunt the respiratory center, which means usage of sedation, right, to blunt the center, to reduce the outflow, right? Sometimes increasing PEEP will help to make the intrapleural pressure more positive, and this will reduce the pendulum effect, right? Reduce the transpiratory pressure swing and probably protect the lung to some extent. And if all this fails, probably a paralysis, a full paralysis or partial paralysis. Now, partial paralysis is not evidence-based. It's just a practice that's used by some of the Italians, which I spoke to. It can be used to sort of drive the like reduce the respiratory drive on this patient. But I think if you want to partially paralyze the patient, you probably need to increase the sedation as well, right? Now, stress index is something that I like because it's very simple. I have a preference to use volume control constant flow in this group of patients. Because when we actually use a volume control constant flow, it gives me this stress index parameter. Now, stress index is actually not an absolute number, although it's written as stress index equals to 1. It's actually a morphology study of the pressure waveform, right? So a very good example here, if I actually give a flow to the alveoli, it generates this pressure time curve, all right? And this pressure time curve on a constant flow will cause a gentle increase in the pressure because the flow to the lung is actually constant up to a point and it cycles off, right? This kind of pattern where we actually look at the morphology of this part of the curve is called stress index equals to 1 because it's straight out, all right? Now, compared to this, stress index equals to 1, how come? I missed out a curve. So, let me play this again. So if the alveoli is actually over distended with this breath, what happens is that instead of a straight curve, this will curve up here. So what happens is that as the alveoli get distended, the compliance will start to reduce. And the compliance start to reduce with the same constant flow going to the alveoli, the pressure will build up exponentially, causing this curve upwards. Okay, so this curve upwards equals to stress index more than 1. Whereas in the third scenario, is this when there's actually collapsed lung and the ventilation goes in and the alveoli start to expand during the tidal volume breath itself. This will cause a drop in the pressure and stress index it's less than 1. So how do we use this in our management of the ventilation of the patients? We can actually use this to titrate PEEP and titrate the tidal volume. If the stress index is equals to 1, I probably won't have to do much on the PEEP that I set or the tidal volume that I set, because one is actually not overstretching the alveoli, and 2, it seems that the alveoli is actually not ventilated well and not opening up during the tidal breath. Whereas if the stress index is actually more than 1, where this one fixed upward, I probably need to relook into the tidal volume and the PEEP that I set. Okay, because when it flips upward, it's over distension. Over distension means strain, right? Remember, there's actually a static strain and a dynamic strain. Static strain caused by PEEP and dynamic strain caused by tidal volume. We probably need to readjust this to get until we get the stress index back to 1. And a third scenario, when there's actually atelectasis and collapse, and the breath goes in, the alveoli actually open up, all right? Which means that I probably need to increase the PEEP until I get a stress index equals to 1. Right, so this is a very simple concept. Of course, there is some pitfalls, especially with a stress index less than 1. For example, if the patient actually has a pleural effusion, there will be compression atelectasis of the lung. Right, this will actually cause the stress index to be less than 1. So the last part of the talk is actually promoting homogeneity. As you know, inhomogeneity causes stress concentration, and stress concentration causes more stress injury, right? So prone position, I would like to sort of change the concept of how we think prone position is. Most of the time we use prone as a rescue therapy to improve oxygenation. But prone position itself is a lung protection strategy. Okay, looking at this diagram in a supine position, when we actually ventilate a patient in supine position, there is actually inequilibrium in the pressure transmission in the lung expansion, where the lung expansion is actually more on the dorsal surface because it's the ribs is actually just tethered to the sternum and it's freely moving, whereas the ribs that are tethered to the vertebra is actually pretty fixed, right? By putting the patient in a prone position, we sort of equilibrate the pressure change. That's one. Of course, the other side of it is promoting recruitment, reopening up the lung, hence reducing the inhomogeneity of the lung. All right. I won't go deeper in the prone position because we're quite apt in managing prone patients and we know when they need to prone the patient from the previous study that we do and on the RDS, right? But I'd like to change the mind frame of the audience here is that prone position is not a rescue therapy for hypoxemia. Prone position is a lung protection strategy itself. Right, and recruitment and optimal PEEP is something that is a bit difficult to actually speak on because most of us, we do practice recruitment maneuver, but we practice it now with more caution, right? But we know that if the lung is recruited and we provide optimal PEEP, the lung becomes more homogeneous and hence less lung injury, right? So there is a balance between recruitment, oxygenation, overdistension, and hemodynamics. Where do we stand? Okay. The question is, when do we recruit? Actually, the question is more of, is the lung recruitable rather than when do we recruit? If they are recruitable, then we will recruit. So how do we actually pick up lung that is actually recruitable? In our IC protocol, national IC protocol, we actually introduced to you all a PEEP trial, putting the PEEP up to 15, and then we assess oxygenation. But there are more complicated ways of doing things, as usual. It's just whether you want to follow. Is to do this PEEP trial in a very different manner, where we start off the PEEP at 5 and then escalate it up to PEEP of 15, where we actually look at the change in mechanics and compliance, as we say that. But when you actually put a PEEP at 5 and ventilating, we measure the compliance. For example, here, we get an X compliance, and we put the PEEP up to 15, there will be an expansion of the alveoli, and there's a change in the volume of the N-respiratory lung volume, okay? But if it's in the recruiter, that means the lungs that actually responded to recruitment, we put a PEEP up to 15, there will be alveoli that opens up that contribute to extra volume here. After this maneuver, increasing PEEP of 5 to 15, and we drop the PEEP back to 5, we basically measure the expired tidal volume. If the expired tidal volume consists of just the volume of tidal volume and the difference in the PEEP times compliance, maybe I'm a bit need to make it a bit clearer. The volume that's generated here is equal to the PEEP that increased, which is 10 times compliance. For example, compliance is actually 20. The tidal volume that is generated by the PEEP effect is actually 100. All right. So if the expired tidal volume they get out from here equals to the tidal volume is set, for example, 400 mils, plus the effect of the PEEP, which is 100 mils, and there's excess of 200 mils. Those 200 mils are actually the recruited volume, right? Which means that the patient is actually have a recruitable lung. It's a bit complicated to understand, but the time is short, so I won't dwell too much into it. So the patient is actually non-recruiter, PEEP probably will go 10 or less. If they're recruiter, then of course, we have to consider whether we want to recruit the lung. All right, but when you recruit lung, you have to understand what the pressure involved, the pressure of the collapsed lung to open up, the pressure of the hydrostatic pressure, the pressure exerted by the chest wall compliance, which can actually go up to 30 to 45. So if you actually want to recruit the lung, you probably need a pressure of at least 30, all right? Using either this constant pressure maneuver or staircase maneuver. And this is actually described in our IC protocol. I won't go into this. I think there is some interest in this, but my concern with APRV is that we're actually dealing with many volumes. The volume occurring at the PEEP high, all right? What tidal volume is acceptable? The released volume, what tidal volume is acceptable? Okay, which one will cause more strain? Which one, how much transparent pressure is actually generated at the high PEEP? All these are questions that are still unanswered. Right? For those who are using APRV, I would say exercise some caution. All right, so I'm putting this as my last slide. If there's any questions, you can direct it into the Q&A, or you can actually unmute and ask. Thank you very much.